Good afternoon. Welcome to the webinar, Implementation and Scale-Up of Home Visiting, Part 2, Planning for Quality Implementation of Evidence-Based Programs. My name is Jackie Count, and I am the HRSA Region 7 Project Officer for Home Visiting and the Early Childhood Comprehensive System. Together with Sharice Johnson, ACF Child Welfare Program Specialist and ACF Technical Assistance Liaison for Regions 3, 5, and 9, we designed this webinar with Section 4 of the Supplemental Information Request in mind. Section 4 requires an implementation plan for a proposed state home visiting plan. Today's webinar will feature two presentation teams to build on the framework presented in Part 1, and it will provide strategies to think about your implementation plan, engage all levels of the implementation system, and plan for sustainability. The first team will describe the Ohio Department of Mental Health decade-long initiative aimed at facilitating the uptake and successful implementation of evidence-based interventions throughout Ohio. The presenters will share lessons learned from both research and practice about factors that account for successful implementation and sustainability. The second team will describe their experience implementing a home visiting evidence-based practice. They will build on the implementation stages described in the webinar on March 24th, and they will provide specifics in each implementation stage that correspond to the requirements of Part 4 of the SIR. Finally, the presenters will talk about the competencies that your implementation team needs to implement with success. Our presenters today have a wealth of experience. The bios are in order of presentation and are brief today to allow more time for you to hear from them. Their contact information is provided at the end of each presentation if you want to know more. The first team features Dr. Phyllis Panzano and Patrick Canary. Dr. Panzano is an industrial organizational psychologist and visiting professor at the Florida Mental Health Institute in the College of Behavioral and Community Sciences at the University of South Florida. She is also the president of Decision Support Services, a research and consulting firm in Columbus, Ohio. Dr. Panzano has extensive research and practice experience and is currently involved with pre-implementation research studies on adoption, implementation, and sustainability of EBPs. Patrick Canary is the director of the Center for Innovative Practices at the College of Public Health at Kent State University. Patrick has extensive experience with the identification and dissemination of youth and family-focused evidence-based and effective practices within the behavioral health system. He has experience in community-based inter-system policy and program development and has consulted with all three levels of the implementation system. The second team features Leanne Barrett, Dana Mullen, and Maria Chinchillo. Leanne Barrett is a policy analyst at Rhode Island Kids Count with core responsibility for early learning and early childhood development policy statewide. She is a leader in the early learning field and spearheaded the development of Bright Stars, the state's quality rating and improvement system. She also staffed the state's pre-K exploration and design committees and is currently the project director for the Rhode Island Nurse Family Partnership Initiative. Dana Mullen is the assistant administrator of programs at Children's Friend in Providence, Rhode Island. She is responsible for the oversight of multiple child and family services at the agency. Dana serves on various committees and collaborations throughout the state as an advocate for family engagement and timely permanency for children in care. Maria Chantillo is the director of health and nutrition at Children's Friend. She has more than 15 years' experience in pediatric and obstetric nursing. Maria was instrumental in the planning and implementation of the first Nurse-Family Partnership Program in Rhode Island. Following the presentation today, there will be a brief question and answer period, as Dana talked about. And today's webinar will be archived on the ECCS website under a Home Visiting tab. You will receive an email with the link in the presentation or to the presentation in the near future. Please know that mention of a particular home visiting model during the presentation does not mean a preference or endorsement for that model over the others. And before we begin, Sharice and I sincerely thank our presenters for their work on this presentation. We would also like to thank Francis Marshman and Jaya Mather from JSI for hosting the event. And now I turn it over to our presenters. Phyllis?
Thank you, Jackie. Hi, this is Phyllis Panzano, and I'm in our first team from Ohio. And what I'm going to be doing today is joining Patrick Canary to give you both a bird's eye view of what happened in the Ohio mental health system in the effort over a decade to facilitate the implementation of evidence-based practices. And then Patrick is going to follow up by giving you a ground-level nitty-gritty view. One thing we're stating up front is that, we all know that sustaining evidence-based practices or really anything in life depends on, what you're doing well in advance of that point of sustainability. So we're kind of giving you a historical overview of what the Ohio Department of Mental Health has found and what Patrick has found in his real-world practice, just to kind of make more salient some of the issues that you really need to be thinking about now, and you probably all are. So my presentation is divided into 3 parts. I'm going to first set the stage very quickly by describing what was going on at ODMH about a decade ago and the formation of coordinating centers of excellence. I'm then, even though this is a research project that I'm going to be talking about, I don't want to get too researchy. I just want to explain to you sort of what metaphors and models we had in mind as we tried to unravel what was happening over time and understand indicators of success and predictors of success and various things that real-world agencies came across in their attempt to implement evidence-based practices. And then I'm going to talk about our more recent findings that point to some factors that seem to be tied to sustaining practices in real-world settings as long as 7 years after an agency started out with a practice. So in terms of setting the stage, right about 1999, the Ohio Department of Mental Health, the director at the time, wanted to come up with a framework so that everybody would be on the same page from case managers on up about what it was going to take to sort of improve the overall quality of services in the system. And that was Director Mike Hogan, who's now in New York, and he identified kind of 3 big pieces to the puzzle. One was to support the implementation of best practices, promising practices, and evidence-based practices, to pay attention to the kind of outcomes that were being achieved in the system, and depending on what was seen, to sort of kind of have a constant eye on ways to improve the quality of services. So this was referred to as the quality agenda in Ohio. What I'm going to be focusing on today is the best practice part of that agenda primarily. So what the department did was the department did a needs assessment kind of statewide and tried to, at the state level, identify some areas of need in the state around services and special populations. So a prerequisite for thinking about what practices to facilitate was that idea that there has to be a documented need. Once that was the case, the department and a whole bunch of stakeholders, said, what else do we need to consider here? And they kind of came up with 2 dimensions that were thought to be very important. One was the evidence base. How strong was the evidence supporting a particular practice? And the other was salience. And what was meant there was this practice or population that the practice was targeted at salient to the community at large in Ohio? Was it something that politicians and the governors could stand behind? And the idea with thinking about salience was, as the practices proceeded to be implemented, it was seen as helpful to have political support to continue those practices, well into the future. So evidence and salience were 2 very important dimensions considered after needs. And the Ohio Department of Mental Health identified 8 practices focusing on kids populations and adult populations, and plotted those on the axis and decided to fund centers to provide education, training, and technical assistance to agencies around the state who, autonomously decided that they wanted to pursue one of these practices, or at least were entertaining that possibility. So the CCO Ease were developed, and they tended to be located in universities or parts of local partnerships. Patrick's center is here at Kent State University. They initially were started out with a CCOE promoting one practice, and the CCOE was responsible to provide support, education, training, and TA on a statewide basis. The roles of CCOEs, generally speaking, were to promote best practices, the practice in particular that they were initially funded to represent. They were to provide training, technical assistance around such things as fidelity monitoring, problem solving, barrier removal, etc., and really trying to strengthen the systems and the local agencies in terms of their ability to successfully implement. So, and the CCOEs really became sort of a conduit for information sharing at the state level. At the same time that the CCOEs had been identified and funding was starting to flow from the Ohio Department of Mental Health to the CCOEs so that they could gear up and start focusing, putting together their business models, the Department of Mental Health, I might need some assistance here because my slides have some automation, so we may have to pass up on that. But at the same time, the Ohio Department of Mental Health was asking the question right up front, and this was in real time, what should we be paying attention to now that will help us understand what we see in the future as the CCOEs go about their enterprise of promoting and facilitating best practice? What should we be looking at? So the Ohio Department of Mental Health, with support from the MacArthur Foundation, funded a study that was called the Innovation, Diffusion, and Adoption Research Project to, in real time, it was a field study, try to gather information that would help folks understand antecedents to success in implementing and sustaining best practices. Whoops. So anyway, the train was out of the station, and we were quickly gearing up to try and learn from this initiative. So from the timeline standpoint, this timeline gives you a big picture of kind of how things were happening in the last decade. The CCOEs received initial funding right about the end of 2000, and we're trying to gear up for that first year. This IDARP study to try and examine what was happening and understand what was happening was funded shortly thereafter. We were gearing up. And during the course of this IDARP study, we had 4 sweeps of data gathering where we were talking to experts like you out in the field who were doing real-world stuff about how things were going and trying to understand what was happening. We studied initially 80 sites that entertained adopting one or more evidence-based practices. 50 of those sites ended up deciding to adopt the practices, and by the end of 7.5 years, of those 50, 42 sites continued to implement those practices. When we gathered information, we were looking to key informants like you and the folks you'd be working with, and we primarily used interviews and surveys to gather information that were structured interviews and surveys, and we also gathered information from folks at the CCOEs who were working with agencies. And that's how we were putting our puzzle pieces together to try and understand what was going on. We also had to review the literature and have a variety of frameworks in mind to help us figure out what questions to ask and to guide the research. And I'm going to describe, rather than sort of the dry research models to you, some big picture messages that were conveyed by the major models that guided us in our thinking and our research study. And so I'm going to talk in terms of metaphors. 4 different metaphors: the card shark metaphor, the launch metaphor, the Russian doll metaphor, and the Dilbert metaphor. The card shark metaphor and model really was geared to trying to understand agencies' decisions to either adopt or not to adopt a particular practice that they were considering. And the message in the card shark model is the decision to adopt depends on calculated risk. The size of your chip stack does matter. So in other words, we found that agencies really were considering adoption within the context of risk assessment, cost benefits, and one of the factors that discriminated agencies that decided to go forward from those that did not, which would probably come as no surprise to you, is how the resources they had to support implementation. And that was not just monetary resources. It included staff expertise, time, and other forms of resources. I apologize for this, but I had I don't really know how to animate my slides, so parts of my slides are not showing. I'm going to see if I can go back and make that happen just for a minute. Hang on. I didn't know I couldn't have animation. Can I get any suggestions from the technical assistance folks how to do animation, or is that not?
Usually if you just hit the next button, it should push us out, but that one does not seem to be working.
Yeah, I apologize, and the slides that will be available to you will include some of the detail that you're not seeing. But what we did find with regard to this first metaphor, and there's a paper published to provide more details, is that this risk-based framework did do a pretty good job of explaining implementers or adopters from non-adopters in Ohio. We also had 3 metaphors that that represented models and frameworks in the literature to explain implementation success. And these metaphors also guided the kinds of questions we were asking of our informants throughout the project. The first implementation success metaphor is referred to as the launch metaphor. And what that metaphor suggests is that initial conditions prior to and at takeoff, when we're talking about takeoff of implementation, have important implications for understanding and explaining implementation success in the short and long term in real-world settings. A variety of frameworks such as stage-based frameworks, and Leanne will be talking about those, readiness-based frameworks, and planning frameworks all support the idea that what happens now, including consensus and buy-in among your stakeholders, will be related to the success you see down the road. The second implementation success metaphor that guided the research is the Russian doll metaphor, which suggests that surrounding conditions and circumstances influence implementation success in real-world settings. There's many, many frameworks out there in the literature that talk about multi-level factors, from funding in a system to agency resources to the attitudes of staff, that have been found to be linked to implementation success. And those are the frameworks we were relying on in coming up with this metaphor to guide our study. So this kind of is another kind of way of thinking about the Russian doll metaphor. And the final implementation success metaphor that affected what we looked at was the Dilbert Metaphor. And that metaphor indicates that innovation implementation efforts rise and fall with how soundly the implementation process is managed. There's many frameworks out there, from the NERN framework, the National Implementation Research Network framework, to Klein and Sora Implementation Climate Framework, that talk about the importance of goal clarity, feedback to implementers, top management support, removal of obstacles, and all those types of variables that are tied to good project management being linked to implementation success. So those were the metaphors that guided what we paid attention to in the IDARP study. So how did that information that we were looking at relate to understanding sustainability 7-8 years later? This is the story that we can tell at this point. The first 2 boxes here in this model, what had we learned by T3 about 5 years into the study? Well, as I mentioned, the first thing we learned is that perceived risk of going forward discriminated adopters from non-adopters. We found out in another mini-study that those agencies that had decided to adopt but then later, 2-3 years later, discontinued were those that turned out not to have adequate resources to continue implementing, or agencies that no longer thought that that particular practice was a good fit to their needs. And we also found that the Dilbert Metaphor, the project management climate, discriminated how well things were going. The agencies that had stronger climates were doing better. So that's what we knew going into time 3, the final phase of the project. So going into time 3, we're trying to understand, this is not working, we're trying to keep in mind what we had learned from the IDARP study, those 3 frameworks that I just discussed, and what was in the literature about sustaining evidence-based practices that might help us better understand what we were going to see for our final round of data gathering. So we had a variety of frameworks that we looked at, including the original IDARP work, and we kind of had the metaphor that sort of guided us into the final phase to try and understand sustained use 7.5 years later, was what we're calling if the glove still fits, keep wearing it model. And what that says is that external and internal developments influence goodness of fit of evidence-based practices over time. So as environmental factors change and things internal to an agency change, the particular fit of a practice that might have fit very well 5 years earlier may not fit so well right now. The framework that guided this research for our gloves fit model had a number of elements. We looked at fit from the standpoint of strategic fit, resource fit, operational fit. We focused on Dilbert factors, project management factors that were going on in an agency, such as these listed here, whether there was a champion, leadership support, dedicated resources, performance monitoring, etc. And we looked at measures of implementation effectiveness, such as fidelity, commitment of staff, so forth, consistency of delivery. We looked at impact measures, clients, organizations, and other stakeholders. And then we also considered the extent to which both agency informants and CCOE informants were telling us the practice was still strongly embedded in the agency. We had a variety of measures that we asked of both CCOE informants and organization informants about those 5 variables fit through assimilation. We found reasonable agreement with what the CCOE folks were telling us and folks in the agencies, with agencies having a slightly more rosy view about how implementation was going, the fit, the climate, fidelity. We found that those big pieces of the model linked to assimilation, sustained use, were strongly connected from fit to Dilbert, the implementation climate, and our success measures. We found that fit, how well what the practice was seen as fitting the organization needs, drove how strong the implementation climate was, that managers were continued to support the practice, and how strongly the practice was still being sustained. We also found that fidelity was a very important discriminator in determining whether or not the practice was being assimilated. And finally, the last couple of notes, what about the CCOEs, these technical assistance centers that had been funded and in place? We found that they made a difference. We found that working relationships between adopting agencies and the CCOEs were very important to understanding whether or not the practice was being sustained. And we also found that held up over time, that prior reports of working relationships with CCOEs explained sustained use 3 and 4 and 5 years later. So overall, final kind of conclusions here is that our guiding models or metaphors led to insights about the EBP adoption decision, the de-adoption decision, and implementation success. In terms of sustainability, we found that CCOE and organizations' points of views generally converge, that fit is an important driver and one which is subject to change, that EBP-specific climate for implementation is very important and linked to quality and also sustained use, and that the quality of working relationships with CCOEs were particularly important to long-term success, at least within the context of this project and the Ohio Mental Health System's work. So I'm now going to turn it to Patrick, and he is going to be representing a CCOE point of view that will focus on sort of ground-level issues related to sustainability.
Thanks, Phyllis. Hi, everybody. I'm glad to have the opportunity to share a little bit and quickly about our experience as a CCOE Center of Excellence. So you can imagine the only slide I really care about that Phyllis presented was the one that answered the question of do the centers make a difference? And, of course, I could have told her that without the research that we do. But it's good to know that the research does support that this notion of having an intermediary function, if you will, and those can come under lots of different shapes and forms, seems to have something to do with the success of not only implementation, but perhaps more importantly with sustainability. So I'm going to just give you a really quick 30,000-foot view of some of the work that we've done. So we were set up to disseminate multisystemic therapy, MST, maybe a practice that's familiar to many of you. But over the years, and we've been in existence now for 10 years, we've expanded our portfolio into a number of other intensive community and home-based services. That's kind of our niche here in Ohio, if you will, really focusing on keeping kids and families together and keeping kids in their homes and in their communities. So that first slide you see there is, it really is now kind of our operational portfolio, if you will, in terms of the services that our center is mostly concerned with. We kind of grew into our identity. I don't know that prior to bringing these centers into existence, anybody had a real strong sense. My guess is that 10 years is a long time to be a center nowadays, as I know that across the country, folks are looking at continuing to talk about this idea as a way to help implement. I just had a conference with one state this week about the white paper they're preparing for their state leadership about the need for a center to focus on particular activities. So I think about the work that we do as coordinating, navigating, motivating, educating, and evaluating. Probably also in there, some people would say that annoying might be a factor, kind of nudging people along. That's part of the role of implementation. But the thing that we are most concerned about is advance? Yeah, I'm just going to give it a second to advance. Yeah, it's not. I should be on slide 3 if anybody from the tech group can help me. One of the challenges in the KIDS system, as you all know out there, listeners, is the notion that we tend to silo what we do for kids. We silo the funding, we silo the interventions, we silo our systems. And to some degree, there's a rationale for that. But I think increasingly we're finding that we probably share some goals and outcomes that heretofore we really haven't. And so part of our role, I think, is to help kind of de-silo the system and bring into the mix all of the variables that we need to. So I'm frozen here, folks. So I'm going to proceed, but from my control panel, I can no longer advance the slides. So if somebody else can do that.
Patrick, they have moved ahead. It's on demonstrate program effectiveness.
Okay. So thank you. So I'm just gonna move ahead. You guys off there in Technoland, just advance for me. So one of the things that we want to make sure we do is that we get out in front of people the demonstration numbers that say this is why there's a value in having an entity that kind of provides that umbrella and oversight. So that that diagram that you see actually should say MST in there more specifically. Those are our outcomes from our most recent dashboard, as we call it. This is the kind of information we push out to our stakeholders, to our funders, that our providers push out to their community members as they want to demonstrate the effectiveness of their programs and why people should invest in them. So having that kind of data is really important. The next slide really looks at the cost-benefit analysis. This is not what I would call, a terribly sophisticated chart, but it is a way for us to capture kind of making a comparison between business as usual, which in our field has largely been treating kids with very difficult issues through residential or out-of-home placement. Clearly that's an important part of our continuum, but I think increasingly we have the technology and the science to help us do more home-based work. So we think it's important to try to demonstrate the cost effectiveness as a motivator on why communities might want to kind of build out these particular programs and add it to their continuum. It doesn't replace anything. This is really about what is the right service at the right time for the right kid. The next slide that talks about fiscal impact is the information we like to push out, particularly to our stakeholders, to say that, everybody has limited resources, and if that's the case today, ought we not be spending our limited dollars on those services that not only have a proven effectiveness clinically, but also can, if we figure out the math, can do it also on a fiscal level. So kind of the bottom line literally on this slide is the notion of that our typical cost for a course of out-of-home placement for kids for in-home treatment, IHBT, for kids in Ohio is about $7,500. But the implementation reality is, and I think you'll see this in much more detail in our friends from Rhode Island, is that the reality of doing all this, despite our good outcomes, despite our financial data, quite honestly, is that there is a hard reality that we bump into, and that is that it's an ongoing process. It's not an event. So to implement something is really only to begin telling the story. And we agree with our friends at NERN that it is indeed takes about 2 to 4 years to take hold, minimum. And certainly other experiences would tell us that in some cases there is good reason for it to take longer. And that we know that the treatment effectiveness is definitely tied to the success and the effectiveness of the implementation at whatever level. No, I think they're. So the next slide, which is the one that kind of shows my risks ahead. So what are the challenges if we're indeed getting all of this good? So the first challenge is really around infrastructure, and so that's the next slide. So these are the things I guess I would say that you need to have in place to minimize that risk. A reliable partner with you in implementation, addressing both the programmatic and the organizational needs, and I know that the Rhode Island folks will talk about this with their implementation project. The ability to turn around data and get stuff out to people almost immediately, I think, is really important. To really have a connection with the developers of the program and have them as part of your partnership. Some ability to take it to scale so that we're not always talking about a pilot project doing one service in one community and that's good enough. I think that's where we get kind of stuck sometimes in the implementation world, is that we don't take it to scale. And I think it's important for us to obviously understand the local dynamics of implementation. There's all these dynamics that take place at the base of the pyramid, if you will, but at that very top of the pyramid where it actually touches the community, that becomes kind of the real spark. So the next issue with my picture of the oasis there is the financing. And the reason I use that picture is that, in a world of shrinking resources, with the pool drying up, we only have a couple of choices. We can either share what's there, or we can all make a mad dash to kind of get our share. And I hope that where we're moving towards is really beginning to look more at the concept of shared outcomes means shared funding, because it means shared improvement in our kids and families and in our communities. Stakeholder engagement is, absolutely critical. Do people that you're working with actually share your vision? Can you say something that they get? And do they say something that you get in terms of why they should support or sustain the program? And I think that what we're finding, at least for the population of kids that we're focusing on, is that there are indeed shared inter-system outcomes in education, in behavioral health, substance abuse, delinquency, and I think we need to do a better job of framing how good intervention really impacts. I kind of think about Phyllis's model of the Russian doll. We've got to influence all those circles and rings, if you will, and our shared stakeholders need to have a shared sense that they're part of that picture. That also, I think, helps encourage people to invest. The next slide, that I've labeled shift in emphasis. This is a little bit of our historical journey here, kind of the then and now. And I'll just, walk you through it real quickly. And when I say then, I mean like perhaps more than 5 years ago. So when we were kind of on our first legs of doing this. I think we felt there was a certain organic approach to this, that kind of just if we were out there talking to people that they would kind of get it and see it. And I think what we found was there's always a sense of early adopters, but that really to make your message known, it really needs to be strategic. I think we were a little naive. I'm not sure that we really surveyed the landscape sufficiently, and I think our change in strategy now is to be much more informed and not to think about things in such a global or generic way, but really think at the very specific community level that we are working with. What community are we working with? What are their variables? What are their challenges? And how do we map those on to what we do know in general are the challenges of implementation and sustainability? I think we've gone from the ideal to the real, and that's a good place to be. I mean, it's always good to have your vision, but the reality is we're working with folks and their real-world tools, and that's what's going to make the difference, is how well we can shape what we do and work with those tools effectively. I think initially we focused a lot more on the specific intervention. We still do that, but we also try to play it out in terms of how does that impact or roll out in terms of a system. In the past, I think we tended to maybe be a little more of a cheerleader than I think we need to be in the world of reality, and I think what we do now is we really highlight the challenges more. I've had folks say to me when I go out and do presentations on MST, for example, and I'll have people say, why are you making this sound so difficult to do? Aren't you kind of shooting yourself in the foot? And my response is, I think you really need to know how difficult it is to do, because I don't want to come back 6 months or a year or 2 years from now and have you really struggling with stuff that I know are going to be the struggles. So I think we really have an obligation to our audience, if you will, to really get out the stuff that we know is a challenge. So I think we've had an evolution in our strategies. That's our friend Darwin there in the next slide. We're more heavily relying on data and getting that information out there. We're definitely have a need to do longer-term outcomes on the kinds of services that we're doing. Some interventions have more of a history of long-term outcomes. Some of the work that we're doing, not as much. So that's a goal for us. Always engaging the policy and decision makers more and more. You can't go wrong, even if there's tension in the room, even if there's the need to kind of resolve things, because that's what you need to do up front. And in our work, we're seeing an emerging stronger alliance in behavioral health with both the juvenile justice and the child welfare system. So what we think we've got right on that next slide is we've got the right vehicle, the content, the process, the data, the relevance, the value, the quality, and the fidelity. And those are not small things to kind of get right. We don't get them right all the time in always that order, but by and large, that's the platform that we've established. In the last slide there, the pieces that we're really still working on and the scheming that we still need to do is strengthening those critical alliances, really moving beyond collaboration into real, genuine partnership, to really move the financing system along with us. I think our financing system is so far behind the knowledge we have about implementing services. Keep on the message regarding cost. Keep on the message regarding fundamental transformation, that you're not just starting a program, that you're really trying to really shape the health of a community, the health of a family, the health of the systems that you're working in. So we need to align our policy and practices. And again, kind of the message we're all getting is this kind of integration with healthcare and policy. It's all about health. It's all about wellness, whether it's under behavioral health or other names. So that's kind of where we are with our journey. We have a long way to go. We've learned a lot, and I know that our colleagues in Rhode Island are going to talk much more specifically about their work. So thanks.
Thank you, Patrick. This is Leanne Barrett in Rhode Island, and we're lucky because we're in a small state, so we're doing it the small state way. We have Maria Ciancio and Dana Mullen and I are all in the same room, so we can all contribute to this PowerPoint together, and we'll be building on some of the good points that Phyllis and Patrick brought up in their earlier presentation. So the overview slide 2 is, so we're having a little delay here, but I'll just keep going. Slide 2. Nope. Okay, on slide 2, I'm giving a little of the background information on how we got involved in evidence-based home visiting in Rhode Island. In 2008, ACS held a national grant competition called Evidence-Based Home Visiting to Prevent Child Maltreatment. Funding was available to support key planning, startup, infrastructure development, and evaluation activities. But the grant required states to leverage other existing funding streams to support direct services. The next slide shows our key partners. Rhode Island's Evidence-Based Home Visiting Project is a partnership from the very beginning. Rhode Island Kids Count, where I work, is the lead agency. We're sort of acting as a planning intermediary with 3 of the key state agencies that are involved: our Department of Health, our Department of Human Services, and our Department of Children, Youth, and Families, which is our child welfare department. So we partnered with those 3 state agencies to apply for the application. Kids Count, just a little more background on us, is that we're a data organization. We publish an annual fact book with over 60 indicators of children's well-being for all 39 cities and towns in Rhode Island. We don't provide direct services to children or families. Instead, we work with policymakers, government agencies, and providers to advocate for effective policies and programs to improve child outcomes. Children's Friend, where Marie and Dana work, is a direct service agency with a long history of providing services to families with young children in Rhode Island's urban core communities. They have a particularly strong history of providing home visiting services, including home-based early Head Start and our state's existing newborn home visiting program known as First Connections. Children's Friend is a partner and is the anchor implementing agency for Nurse-Family Partnership in Rhode Island. The Bradley Hasbro Children's Research Center is a Brown University-affiliated research center, and they are our evaluator for the NFP program in Rhode Island. And I would be remiss if I didn't mention the good partnership we have with our Nurse-Family Partnership National Office, who's provided tons of support to us across all phases of implementation. The next slide outlines our grant goals. We were working on building off of our state's Early Childhood Comprehensive System Plan, published in 2005. So our first goal was to establish an anchor nurse-family partnership site, which is outlined as a priority action strategy in our state early childhood plan, to expand the availability of high-quality intensive services for families with multiple risk factors for poor outcomes. Our anchor site has opened. It opened in July 2010 and serves 100 families in 4 urban communities with blended state funding, and it builds on our existing statewide newborn home visiting infrastructure. The existing newborn home visiting program was a short-term program, is a short-term program with 1, 2, or 3 home visits to families with new babies, and NFP provides up to 64 home visits to families. After establishing NFP, our next goal is to expand NFP to serve at least 250 families by the end of the grant period and to cover all cities and towns in Rhode Island, adding additional implementing agencies as needed. We are also conducting a rigorous evaluation of the model as implemented in Rhode Island. We are tracking fidelity indicators and child and family outcomes. We see evaluation as a key strategy to support sustainability and growth of effective services over time.
Finally, we have an intentional plan to build public awareness and support for evidence-based programs in Rhode Island. In fact, on May 4th, we are holding a statewide policy forum on evidence-based programs and practices, inviting direct service agencies, government administrators, and legislatures. The next slide outlines the implementation stages that Patrick and Phyllis talked about too. These are from NERN, the National Implementation Research Network. As part of our EVHP grant, we had the opportunity to work with Melissa Van Dyke from NERN. I know she presented at the March webinar to this group, and she shared a lot of her concepts there. And we have organized the rest of our presentation to follow the 4 stages of implementation, which often stretch out over 2 to 4 years, or in our case, much longer than that. So next slide is the exploration stage. The exploration stage occurs in the months or years leading up to the decision to implement a new program. The goals of this stage are to examine the degree to which the program meets the needs in the settings identified, to determine whether adoption and implementation of a new program or model is desirable and feasible, and to create readiness for change. Next slide describes the exploration phase in Rhode Island. In Rhode Island, exploration phase for NSP was really over a 10-year process. Interest in the model began in the 1990s during planning for welfare reform. Over the years, there have been many, many meetings involving many, many people focused on improving services for our most at-risk families. During the exploration phase, you begin to identify champions and leaders who can play a role in supporting implementation and to identify systems and planning groups that the program should be connected with. In our case, we connected with a variety of groups, including Successful Start and Teen Parenting programs. Because NSP has a range of proven outcomes for children and families, we have worked with a variety of these groups, including prenatal care and birth outcomes, and groups working to prevent and respond to child maltreatment, among others. During the exploration phase, we reviewed data on populations of at-risk children and communities with concentrations of at-risk children and families. I'll show you some of that data on the next few slides. We also looked at the existing set of services available to families in Rhode Island and models that were working in other states. We also established a relationship with the NSP National Service Office during the exploration phase. They help us understand the model requirements, costs, and financing options used in other states. They can also help you identify agencies that are likely good candidates for becoming a strong NSP implementing agency. The key activity that brought our exploration phase to a close was the effort to write and submit our state's application for the EVHP funding. In the application process, we had to outline a financing plan, identify a service area and implementing agency, and submit letters of support from key partners. This was all done in 2008, but actually we had a practice run with this in 2007 when Rhode Island applied for a smaller ACS competition focused on nurse home visiting. Unfortunately, we didn't receive the grant in 2007, but just the process to put a good, strong application together helps you secure buy-in from the key partners you need. The next slide gives an example of some of the needs assessment we did. In Rhode Island, data on children at risk are updated annually for every city and town and published in the Rhode Island Kids Count Factbook, including data on children in poverty, women with delayed prenatal care, preterm births and low birth weight infants, births to teens, child maltreatment, etc. But as the research indicates, it isn't the presence of any one single risk factor that leads to poor outcomes. Rather, it is the presence of multiple overlapping risk factors in families and children that cause the most worries. We work to understand the numbers of young children in each community with multiple risk factors by examining the newborn risk screening data collected by the Rhode Island Department of Health. The Department of Health conducts a chart review of all Rhode Island newborns to identify risks for poor developmental outcomes, including inadequate prenatal care, established developmental conditions, low APGAR scores, low maternal education, young maternal age, etc. These are put into a database and we can run reports. And as you can see in this table, the middle column shows that 86% of all babies born in the state in this year had at least one risk factor for poor developmental outcomes. We sought to narrow this pool down to identify those babies who were at highest risk because of the presence of multiple risk factors. We chose 3 socioeconomic indicators that can be identified prenatally and that are linked to poor outcomes. They are mother's age, education, and marital status at the birth of the baby. Studies have shown that babies born to single mothers who are under age 20 without a high school diploma are 9 times more likely to grow up in poverty than children without any of these risks. And these babies experience all of the negative outcomes associated with poverty. Maternal age also seems to be especially important for child maltreatment. We've been very impressed by the research in Illinois that shows that more than 60% of the children entering foster care had mothers who first gave birth as teenagers, and 75% had mothers who first gave birth before age 22. So just to walk you through the tables, the cities listed on the left-hand side of the table are the core cities in Rhode Island, or the 6 cities with the highest levels of child poverty. The remainder of the state includes the data from the remaining 33 communities that have lower levels of child poverty. So just looking at the bottom line on the chart, you can see for the state of Rhode Island, we had about 12,000 babies born in 2007. We tend to always have about 12,000 babies born per year. And 10,372 had at least one risk factor, which is 86% of the population, while only 648 had the 3 risk factors I identified earlier. This is only 5% of the population and a much more manageable number. And as you can see, most of those babies live in the core cities of the state, with a very strong concentration in Providence, our largest city. The next slide talks about how we're reviewing options for programs to meet the needs of high-risk families. In 2005, Rhode Island conducted a statewide inventory of parenting and family support programs, and we outlined a continuum of supports arranged by the intensity of family needs and risks. This issue brief recognizes that all families need and benefit from support systems, but that some families, and we believe it is a relatively small number, probably less than 10%, really benefit from the availability of intensive, comprehensive, long-term parenting support. We concluded that there were not enough high-risk, high-quality, intensive programs meeting the needs of families with multiple risk factors. We recommended in this issue brief that the state consider investing in a program like NSP and also expand access to early Head Start. These recommendations were also included as priority action strategies in the state's Successful Start Plan, which was released in 2005. Okay, my next slide is the last slide with data on it. It shows again how we went deeper into the data as we looked at specifically implementing NSP. And it's identifying the potential eligible population. We had the health department run data for us on the number of births paid for by Medicaid, which would indicate the mom was low income, and that were first-time births, and we did it by city and town, or you could do it by county or by region. We had the data also run by maternal age, since we knew there was a strong connection between maternal age and risks for child maltreatment, and our key target outcome for the EVHC funding is reducing child maltreatment. So the data is organized by regions that the state uses for other kinds of systems projects, including First Connections and our child welfare program. And this data helped us in planning for NSP and clearly shows that the place to start NSP was in the core urban region. So now Dana will talk a little bit more about how Children's Friend handled the exploration stage.
Hello, I'm Dana Mullen, Assistant Administrator at Children's Friend, the implementing agency for the Nurse-Family Partnership. Our mission at Children's Friend is to promote the well-being and healthy development of Rhode Island's most vulnerable children by providing flexible, effective, and culturally relevant services that support and strengthen families and communities. That being said, the Nurse-Family Partnership fit in nicely with our agency services and programs that serve pregnant mothers and their families. Children's Friend began its Early Head Start program in 1999, Early Intervention in 2000, and became Rhode Island's first connections contractor in 2007, providing nursing and social work home visits to newborns, infants, and parents with specific risk factors for poor developmental outcomes. For years, Children's Friend had several programs that serve pregnant mothers and their children. However, none of these programs have a nurse home visiting program that is of the duration of the Nurse-Family Partnership and that is evidence-based. In 2007, Children's Friend hired a new executive director. Shortly after that, the request for proposal came out for the Nurse-Family Partnership program. Our agency's management team and the executive leadership team met and agreed that this program fit in nicely with the agency's mission. Children's Friend staff met with other agencies in Rhode Island to determine which agency would take the lead and which agencies would support the implementation agency. Because the grant supported systems building and infrastructure, it made sense for HughesCount to become the grantee and Children's Friend to become the implementing agency. I'm now going to turn it over to Leanne, who will talk in greater detail about Rhode Island's exploration.
Okay. So in the final stages of exploration, we were completing our ACS grant application, and we worked intensively with the NSP National Service Office to better understand the model. Our grant planning team included state agencies, private funders, and other key stakeholders. We were able to secure a letter of support from the NSP office for the Rhode Island application, which was very helpful. A key activity during the stage, again, was to clarify the startup and operating costs for the model in Rhode Island. NSP has a base budget, but it needs to be customized for your state, including developing a specific staffing plan and plugging in, adequate Rhode Island salaries and benefits to attract and retain nurses. And we worked hard to develop an initial financing model and secure funding commitments from partners. Our financing model is illustrated on the next slide. And on this slide, you'll see the cost per child per year for NSP in Rhode Island is $6,500. This is for a core program including 4 full-time nurse home visitors and a full-time nurse supervisor. We also have enhanced the basic NSP staffing plan by building into our model funding for a dedicated interpreter and a part-time consulting social worker. The financing model on the slide shows the funding sources in green circles and the intermediary organizations as blue diamonds. The solid lines and arrows reflect the relationships and funding mechanisms that are in place now for the model, and the dotted line for Medicaid funding is still in the planning phase. We have worked to understand the outcomes that funders are seeking to achieve by investing funds in NSP, so we can make sure to track these outcomes in our evaluation. For example, the health department is investing WIC outreach money in NSP and is particularly interested in improved children's health, nutrition, and development, support for breastfeeding, and improved prenatal health and birth outcomes. The Department of Human Services TANF office is investing TANF funds in NSP and is particularly interested in improved maternal education and economic self-sufficiency, reduced percentage of repeat births to teens, and increased birth intervals. The Department of Children, Youth, and Families is investing child maltreatment prevention funds in NSP and is particularly interested in reduced child maltreatment and reduced out-of-home placements, while the Medicaid office is particularly interested in improved health outcomes for both mothers and children and cost savings associated with reduced use of the NICU and emergency room visits. So it took a lot of time developing that financing model, and the next phase, installation, is actually more work to get the mechanisms in place for the funding. So slide 14 shows the NERN overview of installation, the goal of installation is to work to make the structural and instrumental changes necessary to initiate services. The next slide talks about Rhode Island's activities during this phase. We were very focused on the work to establish financing mechanisms, including contracting and billing. We are actually still working on that. After startup, with a blended funding model, the work involved in setting up these systems is significant. We also had to pay attention to the associated reporting and accountability requirements associated with each of these funding streams. We established a formal advisory committee structure for NSP during the installation phase, which works to connect the program to Successful Start, our state early childhood comprehensive system planning effort. Children's Friend works closely with the NSP National Service Office during this phase to complete the implementation plan and have it be approved by NSP. They have to do a formal approval of each implementing agency. And Dana and Maria will talk about those activities now.
The Nurse-Family Partnership application was a lengthy process, taking over a year to complete. It involves working with multiple public and private agencies to gather relevant data. The application must establish the community need for the Nurse-Family Partnership program. In Rhode Island, as Leanne mentioned, we reported numbers of babies born in the proposed communities and data on, of those births, how many were considered high-risk births. We also reported Child Protective Services investigations and data indicating that the 0 to 3 population in Rhode Island comprised almost 1/3 of the Department of Children, Youth, and Families caseload. The application requires the agency to report on other comparable programs in the community. In Rhode Island's case, there was no nurse home visiting program of this duration. We were also asked to demonstrate our agency's commitment and alignment of nurse-family partnership with our mission. Children's Friend had over 175 years of providing services to high-risk, low-income children and families. Children's Friend had a proven history of nursing services, home visiting, working with pregnant mothers, and reaching children in their earliest years. Our agency also had experience in implementing other evidence-based programs such as Early Head Start with Fidelity. The application also requires agencies to report on its ability to use data to monitor program performance and quality. and the application required us to report on how we would recruit nurses and how we would retain nurses. The agency must demonstrate its ability and commitment to provide ongoing reflective supervision to nurse home visitors. We were asked to establish a recruitment plan for enrollment into the program and to describe existing community linkages that would help to ensure sufficient referrals. The component that took the longest for us to secure was the financing piece. The National Service Office required us to have signed letters of agreement describing a 3-year financing plan and how the program would be sustained locally before we could submit our application. All of this was required, as I said, in advance in order to establish Children's Friend as an appropriate nurse-family partnership implementing agency. I'm now going to turn it over to Marie Ciancio, who will further talk about Rhode Island installation and implementation.
Hi, I'm Maria Ciancio. I'm the registered nurse overseeing the nurse-family partnership here in Rhode Island. And on slide 17, you will see some of what we needed to do to have this program up and running. Dana talked to you about the process of completing the application. And upon receipt of our acceptance letter, which was in February of 2010, the NFP National Service Office provided us ongoing support via telephone and email almost daily as we needed it. We were immediately notified by our state nurse consultant, who is very much active with us today daily, and together we spoke about the information and materials we would need to implement NFP. We at that time developed a timeline to guide us in this process so that we would stay within the time frames and really get this program up and running. Within days of all of this happening, with the acceptance letter being notified by our state nurse consultant, we received our implementation orientation packet, which was mailed to our agency. In this was all the important information that we needed, including information from the space we needed for staff, sample job descriptions, interview questions, how to establish a network of referral sources that refer low-income first-time moms, how to inform the community, how to work with the media. The Nurse Family Partnership Office has been supportive to us 100% of the way. They've provided us with the visit-to-visit guidelines and all the materials to help the nurse supervisor and the nurse home visitors implement this program with fidelity to the model elements. We have gone through a data collection change. Originally, when we began this program, it was called CIS. We are now calling the data collection efforts to outcomes. They have supplied us with the data collection manual, with the introduction in the process of gathering and recording the clinical and program indicated data that we need to do daily. Also available is the ETO user manual, which provides information on assessing, entering data, and generating reports. During this initial implementation stage, we had a great advantage. We were able to visit an existing site in New Jersey, which was extremely helpful. I went along with the supervisor and 2 of the nurses to actually see the program up and running in New Jersey, which helped us immensely. When we went on to hire the entire team, we began the NFP education series, and that will be on slide 18. You will see the difference between the trainings that is offered and which needs to be completed by all of the nurses before this program is actually up and running and we are seeing clients. So we started with Unit 1, which was a distance course designed to equip newly hired nurses and the supervisors with the foundational knowledge of NFP and the home visiting intervention. And this we did here in Rhode Island. On Unit 2 was a face-to-face week-long education series designed to build on the foundation of Unit 1 and to prepare new home visitors to implement the program with fidelity to the NFP model. The entire team, including the interpreter, went to Colorado for 1 week. And along with all of the trainings that was happening there for Unit 2, we were able to network with other existing programs that were already running the NFP, which
was very helpful to us. Unit 3 was a distance course that provided the nurse home visitors with the chance to deepen their understanding of the NFP model, specifically in regards to infant temperament, motivational interviewing, and model fidelity. The supervisor and myself as the administrator went back to Colorado for an additional distance education and also had the lessons on how to orient the supervisor to the new NFP role and responsibilities. Unit 3 for supervisors also received instruction on assessing the quality of the nursing practice and implementation. Unit 4 was a face-to-face education session for the supervisors only, focusing on promoting supervisory skills around team building, job stress, and burnout. And it also builds on reflective supervision, which we offer weekly to all of our nurses, and which we also have the ability to have our licensed clinical social worker who meets with our team on a weekly basis and more as needed if that is the case for them. The national office has been an incredible support to us, and they are still a support to us on a daily basis. They have come for a visit. They will come again in next May to see where we are going, and we have daily supports with them, so we are very grateful for their support. Thank you.
Okay, back to me again for slide 19. The two key challenges highlighted around the installation phase are things that Maria brought up. Any new program requires startup resources, and we were very fortunate to have dedicated funding from ACS to support the planning and the startup activities, including the intensive training that was required to occur before clients could be enrolled, because there aren't a lot of financing and billing systems to support an agency startup before they serve clients. The other key challenge is associated with the fact that a new program brings changes to an agency and to the community. Whenever possible, it helps to anticipate these changes and work to keep people informed and part of the ongoing planning process. Slide 20 is where we are now, initial implementation. As a new program starts up, the goals for initial implementation stage are to survive the awkwardness of startup, learn from mistakes, continue efforts to keep key people and groups informed and supportive, and to manage expectations for services and initial outcomes. In Rhode Island, I mentioned we are right in the middle of initial implementation now. The NFP program began enrolling clients in July 2010, immediately after the nurses returned from Unit 2 training in Denver. NFP provides intensive consultation to new sites to ensure sites start out with strong practices and learn as they move along. We worked hard, Children's Friend worked very hard to clarify referral systems and mechanisms for NFP. They've built very strong relationships with referral agencies that are continually strengthened and solidified. We worked to launch an official NFP implementation team in August 2010 based on the NERN recommendations, and I'll get into those in the next couple of slides. We held a high-profile launch event with U.S. Senator Jack Reed, who is a key champion for the NFP program in Rhode Island. This event generated some initial media coverage of the program and featured stories of clients who are benefiting from the program. We are continuing to work on media planning as we have a reporter interested in following a nurse on home visits, and that's just something to anticipate during the early startup, is that you're probably going to have some people who want to write articles about it. Another key activity during this phase has been coordinating services with other systems and programs, such as First Connections, I mentioned short-term home visiting program. We wanted to avoid duplication of services and to improve the effectiveness of NFP by having it be clear to a family what the primary program that they're enrolled in is. We worked out systems so that NFP clients would not also get a First Connections home visit. We clarified that NFP would be considered an alternate program to the state's Youth Success Program for pregnant and parenting teens who are receiving cash assistance, so clients would not have to participate in two similar programs. Children's Friend has also worked closely with NFP to plan enrollment cycles over this past 9 months so that clients are spaced out. The initial pattern of client enrollment is a key factor for long-term success with NFP, as you want to make sure that you have clients at different stages and you don't have all the babies being born at once. Nurses need to be able to manage all their clients, recognizing that family needs intensify right after the birth of the baby. And finally, we continue to work on financing and sustainability. We still have financing mechanisms that are in the discussion and development phase.
Slide 22 is the background from NERN on the recommendations to establish implementation teams to strengthen a program rollout. This slide shows that strong implementation is often guided by a team of individuals that are committed to ensuring the program is a success and will take action to address challenges and make system improvements. Leaving responsibility for implementation in the hands of a direct service agency by themselves is often not successful. Slide 23 talks about implementation teams, and they're a relatively small group of individuals who are charged with guiding the overall implementation of the program. In addition to representatives from the implementing agency, a high-functioning team includes key representatives from critical systems, such as key community referral and service linkage programs, funders, and other relevant systems that work with the same clients. The teams can provide a focused and accountable structure to increase the likelihood of success. Core competencies for implementation teams from NERN. And we worked very hard with NERN as we designed our implementation team to think carefully about the membership of who to include. And we know we needed to know at least some representatives who know the innovation and implementation very well. In our state, we didn't have an NFP yet, so we really needed to include representatives from NFP National who's been actively involved. They know the NFP model the best, and they know implementation struggles and successes very well as well. We have members who know about improvement cycles, continuous quality improvement, and how to identify and make changes to improve implementation over time. And importantly, they know about and are capable of making changes within related systems in Rhode Island at multiple levels to create hospitable cultures, policies, and funding streams. The Rhode Island implementation is on slide 25. We've included representatives from the key state agency funders, Health, DHS, and DCYS, representatives from other relevant state systems, including home visiting and community health centers. As I mentioned, we have the active involvement of the NFP National Office with our program developer and our nurse consultant. We have high-level managers at Children's Friend at the table, along with Rhode Island Kids Count and our evaluator. The key components that NERN talks about a lot that I totally agree with is that for successful implementation, you need multiple leaders. You can't just have one leader. And you need to have a very strong agency who understands the value of evidence-based programs and is capable and interested in working with a model purveyor, which takes a certain kind of skill. And you need people who represent various systems that have the ability to intervene with the system to make implementation easier. Slide 26 talks about our goals for our implementation team. Our first goal is to ensure that NFP is strong, meaning that it is implemented with fidelity and is effective at improving outcomes for vulnerable children, and that NFP is sustainable in Rhode Island. Our second goal is to assess and facilitate NFP's fit with other family and children's services in Rhode Island. Our third is to assist with connecting ineligible families to appropriate services. We think that it's critical, as you are always going to have families referred to the program who are not eligible. For NFP, they could be families that are having a second child or women who are identified too late in pregnancy, past the 28th week of gestation. They really can't get into NFP, but you're going to get those families referred to you. And we work to keep track of these referrals and advocate to ensure that there are a variety of options for families, especially those with high levels of risk factors. We've also had periods during this initial year when the NFP program could not accept eligible families because of the enrollment guidelines from NFP National that are designed to space out clients. Our final goal is to assess the demand for and availability of services for families. We know that by the end of the initial year of operation, the NFP program will be full to capacity. We will then need to look at management of referrals and enrollment, linkages to other programs, and to consider NFP expansion. Key topics we discuss at our regular meetings include, are we reaching the most vulnerable families? Is the model being implemented with fidelity? Our goal is to improve fidelity over time. Of course, we always talk about financing and sustainability issues. We discuss coordination of NFP with other services and systems, and we discuss successes and challenges. For example, at a recent meeting, Children's Friend shared challenges that some clients were having accessing contraception at hospital discharge and or at the 6-week postpartum visit. Because we have the right people at the table, we are able to follow up to address this challenge by having the health department intervene with community health centers and other providers. This kind of system intervention helps not only the clients in NFP, but other families as well. One of the key benefits of the implementation team is that systems-level problems can be openly discussed and improvements can be made. Oftentimes, implementing agencies and staff on the front lines are well aware of a system problem, but they feel powerless to fix it. They can try to help one family at a time, but they often don't have the right connections or authority to address systemic issues. Slide 27 is full implementation. This again is from NERN. The final slide outlines goals for full implementation, where you continue to work on improving your frontline practice, you build agency-wide supports, you strengthen your frameworks and linkages, and infrastructure and data systems. In full implementation, the program components are integrated and fully functioning. Program staff are fully competent and skilled at implementing the program model with a variety of clients and situations. Often there have been changes in policy at the agency, system, and state levels, and ideally the program is ready to be evaluated for expected outcomes. To note that we are still working toward full implementation as the model rolls out in Rhode Island. It takes 2.5 years for your first client to complete NFP, so NFP considers a 3-year timeline for new agencies to become fully skilled and experienced at implementing all the components of the model. And our last slide, slide 28, again, gives our contact information. We'd be happy to answer questions about our experiences in Rhode Island now, or you can connect with any of us at any time. We'd be happy to talk with you. Thank you.
Hello, this is Sharice Johnson. We would like to thank our presenters for such a wonderful presentation, and we hope that you found this information both informative and useful as you continue with developing your state plans. This is the Q&A portion of the webinar. We have several questions, and the first question is to Rhode Island. How many families or children are being served by the Rhode Island Nurse Family Partnership Program?
Hi, this is Maria. I can answer that for you. At this point right now, we have 69 clients being served. We will be servicing 100 clients, and our time frame for that is June 1st. So we will be serving 100 as of June 1st. Right now we have 69.
Thank you. The second question is directed to Patrick. Patrick, will you talk a bit more about moving beyond collaboration?
Sure. That's probably the word that we've used the most in our field over the last, probably decade. And I think what it conveys to me is, collaboration is a willingness to kind of come together to, share thoughts, even maybe come to some shared agreements about the kinds of things that need to be done. I think that's different than going to the next level, which is more of a partnership, which I think is expressed more about a shared risk and benefit with implementation, as opposed to you're the implementer, and yes, I'll be happy to help you out. I'll be happy to support you the best I can, give you the data that you need, that to me is really good collaboration, and we need that. I'm not saying we don't need that. But I think from an implementation point of view, what we're finding is that implementation really requires a strong partnership and commitment to the intervention that is being implemented. So it could be a funding partnership, and probably should, given the situation that most states are in now, and a partnership that actually agrees on what it is that we're going to kind of measure and use as outcomes. So I think it kind of pushes beyond kind of coming together in a collegial way and taking it to the next level.
Thank you, Patrick. A third question, and it's for any presenter. The caller would like for you to talk more about the intermediary agency and their role in the implementation process or the implementation system.
This is Patrick. I'll take that just real quick, because I think that in implementation world, the notion of an intermediary organization is actually, I don't know if I would say it's common, but it's not rare. So that what you've got is on one end of the continuum, you've got the intervention. So let's just use MST as an example here. On the other end of the continuum, you have the provider who is going to be responsible for the actual implementation of that program. The role that we play in Ohio is that we provide all of the technical assistance, the training, the coaching, and the support to the provider to see that that program gets implemented effectively. We also can be used as a way to help join stakeholders together in the providers community, just as I was saying about the notion of partnership. So we play a role not only in the actual intervention of the service, but also in the setting the tone and the environment for actually having a successful implementation. And Phyllis has a comment.
Yeah, and I would add to that in the Ohio experience, in most cases, the intermediary organization was not the developer of the practice. It was an organization that had expertise, was in good communication with the developer, and expanded the developer's capacity to assist folks with scaling up, whether it be at the state level or community level. We did have a couple of instances where in Ohio where the intermediary organization was also the developer of the practice. And one thing we picked up more from qualitative information than anything else was that agencies often responded very differently to that sort of a situation, in that they potentially felt that the intermediary organization, was really selling the practice based on an interest, a direct interest on the developer end. So that is something to think about. And one other thing that I will say in Ohio, and I think it became evident by Patrick's description of what the Center of Innovative Practices is up to. Initially in 2000, when the CCO Ease were funded, it was to represent one practice statewide. And a couple of the CCO Ease continued to do that, but folks like, Patrick's group, a group at Case Western University, has expanded well beyond representing one practice. And so we see differences throughout the state of Ohio in that aspect of the intermediary organization also.
Thank you, Phyllis. That was great feedback, and Patrick as well. The final question is directed to Rhode Island in regards to talking a bit more about your implementation team and any lessons learned as you develop this strong team to support your work in Rhode Island.
We had our group of individuals working on behalf of NSP towards implementation over the exploration phase and the installation phase. We didn't really officially launch the implementation team until after services started. So I think I would do it now is start it earlier and officially name it, give it a clear charge and direction from the beginning. You can always add people. People can, come on and go off as the case may be, but it's helpful, I think, to have it be relatively small. We have usually 10 people approximately at the meeting. During the early implementation, we had monthly meetings. We're now having meetings every other month. Our agendas often, sort of follow what we talk about enrollment. We recently started doing a case review, which is very helpful actually in highlighting systems challenges. We talk about the financing, and we actually talk about the evaluation at that meeting as well, because we have a whole other complicated evaluation system going on related to the EDHD grant that has to be coordinated with the regular rollout of NSP as well.
That concludes our Q&A session. We appreciate all the questions that were submitted. And at this time, Jackie Counts will close out this webinar.
Thank you, Sharice. And thank you very much to all the presenters today. We have had a wealth of information and experience about implementing evidence-based practices. I know it's a lot to absorb, so I encourage you, if you have questions, to use these resources and experiences, and the presenters have all graciously agreed to answer your questions in the future. So with that, I conclude and say thank you very much to everyone. Good day.